All right, so I'll go ahead and get started then, right?
Okay, yeah, that sounds good.
Okay. All right. Hi, everyone. Good afternoon, whoever are attending. My name is Deep Sharma. I'm one of the renal attendings. And I'm going to be talking to you guys today about, it's a glomerulonephritis talk, and I kind of merged it into a rapidly progressive glomerulonephritis, or RPGN, because most times a GN presents as an RPGN. So this talk is more like an RPGN type talk. So we'll start off with two cases. I just want you guys to keep that in mind, and then we'll come back to these two cases at the end of the lecture. So yeah, don't feel too pressured to answer them, and hopefully by the end, at least you'll have some insights into what these questions are asking. So this is the first one. This is a 56-year-old woman. She has type 2 diabetes for 6 years, and she presents with hematuria, proteinuria, and an AKI. Her creatinine at this time is 2.1, and 3 weeks prior to this, she was admitted to the hospital. She had an open cholecystectomy done. It was complicated by MRSA wound infection, and she's been treated with a cephalosporin. At that time, her creatinine was normal, so this is a definite AKI that she's presenting with now. In the blood work that was done, the one significant thing is that a C3 level that was checked is 64 milligrams per deciliter, and the normal for that is 90 to 120. So the question is, the biopsy is done, and which one of the following is the most likely findings to be observed upon immunofluorescence examination of a kidney biopsy specimen? And the options are either scanty IgG deposits in the mesangium. Is she going to have linear IgG deposits along the capillary wall? Is she going to have mesangial and capillary wall deposits of IgA and C3? Is she going to have granular mesangial deposits of C1q, or is she going to have granular capillary wall deposits of IgG and C3? Okay, so just keep that in mind. It's mainly asking for immunofluorescence findings on biopsy. The second case is of an 80-year-old man. He was admitted for evaluation of progressive, 2-week history of progressive fatigue and darkening of the urine. He does not have any lung findings, no fever. On physical exam, he has some lower extremity edema, but otherwise everything else is normal. His lab studies show serum creatinine of 6.4, and 3 months ago it was 0.9, so he has an AKI as well. He's oliguric, 24-hour urine of only 200 ml. A kidney biopsy is done. It shows necrotizing glomerulonephritis that involves 100%. There was 22 glomeruli specimen sampled in the specimen, and it has concentric GN in 100% of them, with linear deposition of IgG along the glomerular basement membranes. You do serologies, and they come back positive, and it's dual positivity for both anti-GBM and NPO ANCA. A chest X-ray done was normal. He requires initiation of dialysis on the 3rd hospital day. And the question is, which one of the following is the most appropriate management for this patient? So what it's trying to get at is, what diagnosis does he have? Does he have anti-GBM disease, or does he have ANCA vasculitis? And hopefully, when we talk through the lecture about the immunofluorescence, you'll be able to come up with a diagnosis. And the question is, which is the most appropriate management? Do you provide supportive care and management of his end-stage renal disease? Will you give him high-dose corticosteroids, plasmapheresis, and cyclophosphamide? Option C is intravenous rituximab, 1,000 milligrams 2 times 2 weeks apart, or high-dose corticosteroids plus rituximab. So keep that in mind as well. So when we talk about RPGN, what exactly is RPGN? It is defined as a progressive loss of renal function over a short duration of time. So typically days or weeks, like the two patients that we presented with. They had normal kidney function until recently, and now they're coming in with AKI. And the classical feature of this is that this AKI has features of glomerular disease. This AKI is because the glomeruli is involved, there's inflammation in the glomeruli, and that is what defines it as a rapidly progressive glomerulonephritis. There is glomerulonephritis or inflammation in the glomeruli, and there is rapidly progressive worsening of kidney function. The presenting complaints are typically hematuria, decreased urine output, hypertension, and edema. Those are the 4 features that we usually ask the patients for or look for, but it's not necessary that it has to be present in every one of them. In more commonly, actually, rather than these presenting symptoms, it has a more insidious onset with fatigue and edema. And the hallmark that you see for patients with RPGN is on kidney biopsy, you have extensive crescent formation, and we'll show you during the course a few pictures of what a crescent looks like. And for that reason, this term RPGN is sometimes interchangeably used with the pathologic term that is crescentic glomerulonephritis. There are also two mainly other diseases that can also cause RPGN, where you have glomerular involvement and an AKI, but not crescentic GN, the ones that we talk about. And these two are thrombotic microangiopathy and atherosclerotic renal disease. And we'll not be talking about these two conditions, but just keep in mind that these are the ones where you have a glomerular disease causing an AKI, but you don't have the crescent formation as you would see with the other ones that we'll talk about. So when we talk about RPGN, the spectrum of diseases mostly that we see in patients, they can either have a spectrum from asymptomatic hematuria or proteinuria, or to a rapidly progressive nephritis where they have severe AKI and a lot of inflammation. So when you look down, the chances of them having, if they have an RPGN or rapidly progressive nephritis, they're more likely to have ANCA vasculitis and anti-GBM nephritis. In fact, ANCA vasculitis is the most common diagnosis. In the older people, when you do a kidney biopsy for GN, ANCA is the most likely diagnosis to be found on biopsy. Lupus nephritis can present on both sides of the spectrum, and IgA nephropathy is one of the conditions that presents more on the asymptomatic hematuria and proteinuria side of things. So if you have somebody that is referred to you for just asymptomatic hematuria, a little bit of proteinuria, maybe a slight decrease in kidney function, you're more likely to find IgA nephropathy. Whereas if they have hematuria, proteinuria, and a severely worsening kidney function, you're more likely to have ANCA and anti-GBM, and lupus nephritis comes in between those. So those are the most common diseases that you would encounter in people that have these findings. So hematuria in patients with GN is likely, but it is not necessary. So these are two studies that I pulled up to illustrate this point. The top one is a more recent study published in 2010. It was looking at patients with ANCA vasculitis that were randomized to either get rituximab or the standard of care at that time, which was cyclophosphamide. And they had a decent number of patients, about 200 patients in the study, yet hematuria was present in only about 30% of patients that had renal involvement. So it is common, but it is not necessary that you have to be there. So if you don't see hematuria, don't say, or microscopic hematuria, don't say that the patient does not have a GN, because it can be something that is episodic, and if you have a urine specimen during a time when they're not having hematuria, you may miss that. At the same time, this was an older study in 2005 that was looking at patients with post-infectious glomerulonephritis, and in them, interestingly, there were 23 patients, and all of them had microscopic hematuria in those that were diagnosed with post-infectious GN. So it can be very variable. You can have a lot of patients having microscopic hematuria, but it may not be present in everyone. So don't let that take you away from the diagnosis that this patient could have a GN. The other part is also proteinuria can be variable. So typically we say, whenever the glomeruli is involved, and glomerular proteinuria is about 3 grams of protein or more in a 24-hour period. But in patients that are presenting with GN, even though there is glomerular involvement, there is so much inflammation, and you may be able to pick up the patient so early on in the disease that they don't necessarily have to have nephrotic range proteinuria. So for this, this was a study that was done in patients with lupus nephritis. This was the ARMS trial that was randomized to either get mycophenolate or cyclophosphamide. And in them, if you can see, most of these patients, class 3 and class 4 lupus nephritis are the ones that cause a GN or inflammation in the kidneys. And most of the patients had that, yet the amount of mean protein in the urine was only around 1 gram of protein for 24-hour period. So while they should have proteinuria, it should be abnormal. It does not necessarily have to be in the nephrotic range. And the third thing also that is important is you do want to look for extrarenal involvement. We talked about some of these diseases like ANCA vasculitis, anti-GBM disease, lupus nephritis. They're very classical for having features that are not just confined to the kidneys, but that involve other organ systems as well. This was the same RAVE trial that was done looking at rituximab for ANCA vasculitis. And in them, you can see the findings. You have ear, nose, and throat involvement in 75% of patients, lung involvement about 83% of patients. You have peripheral nervous system. You can have vasculitis of the nervous system in about 25 to 30% of patients. And skin involvement, where you have the leukocytoclastic vasculitis, was present in about 30% of patients. So some of them also had cardiovascular and GI involvement. So you always want to take a very careful history, asking them about ear, nose, and throat symptoms if they have cough and hemoptysis, runny nose, bleeding from the nose, signs of peripheral neuropathy, any skin rash. All those findings are important when you're taking a history, because these diseases can also present with extrarenal involvement, and it will help lead you towards the diagnosis. So then, coming back to the kidney aspect of things, on biopsy, we said that the most classical finding of RPGN is this crescentric GN. So when you look at this biopsy, on the left side is a normal kidney biopsy, right? So this is what you're looking for, are these capillary loops, which are nice and open, right? You have nothing inside the capillary loops, and you're looking for cells in the capillary walls. Typically, you should have about one endothelial cell per capillary loop. And you see in this, it is pretty normal. You have open capillary loops. There is no increased cellularity and no obstruction of the capillary walls. Whereas this is a patient with a GN. You see this necrotic material that is pushing the glomerular, the tuft towards one side, and this is a crescent that is formed because of the severe inflammation. The crescent can either be a cellular crescent. If you do the biopsy early enough in the inflammation, you have this crescent formation with a lot of inflammatory cells. And as time goes on, if you delay the biopsy for a while, then this crescent can become organized and become a fibrous crescent. So that just indicates chronicity. But the fact that you have a crescent indicates an acute event. And also in the capillary loops, like if you see this, on the normal side, you have open capillary loops. Here you have many of these capillary loops that are closed, that are filled with these red blood cells, filled with inflammatory cells, and also the number of cells in each of these capillary walls is more than one. So they have more cellular infiltrate in the capillary loops. So this is what you would see in patients with biopsy findings of all these patients that have RPGN or that have crescentric GN. You have glomerular inflammation, and the inflammation is severe enough to cause disruption of the glomerular capillary walls, leading to this inflammatory infiltrate and necrotic material causing a crescent formation. So in these patients, while most patients have the same classical features on light microscopy, we classify them based on what we see on immunofluorescence. So whenever you have a patient that gets a kidney biopsy, you always send it for three things. One is looking at the light microscopy. The second one is you do immunofluorescence microscopy, and the last one is electron microscopy. You're looking at the biopsy under electron microscope. So while the light microscopy findings all show glomerular inflammation, it is on immunofluorescence where we classify patients with RPGN. So on immunofluorescence, you can really see three patterns of staining on immunofluorescence microscopy. Either you can see linear staining of IgG in the glomerular capillary walls. I have a better picture, a colored picture, but this one is just showing linear staining, and that is what you see with anti-GBM disease. The other side of things, you see granular staining of IgG. So instead of it being linear, where it is staining the whole glomerular capillary loop, here the staining is more in a granular pattern. It's not a linear staining of immunoglobulin IgG staining. And you see that with lupus nephritis, IgA nephropathy, post-infectious GN, and MPGN. So we'll be talking about these three, lupus, IgA, and post-infectious, during the lecture. And each of those have their specific staining patterns, and we'll come to that when we talk about these diseases. So on the one side, you have linear staining of IgG. On the other side, you have granular staining of IgG. And in the middle, you have no staining or a paucity of IgG staining. So if you have light microscopy findings of severe inflammation and crescent formation, and on immunofluorescence, you don't see much staining, then those are the patients that have ANCA disease. So that's how you classify them based upon the immunofluorescence findings. Okay. So this is in patients with lupus nephritis. The immunofluorescence staining is not just, so this is the granular staining of IgG, right? So you see the glomerular capillary loops, also some mesangial staining of IgG, and the staining is not linear. You see it in a very granular pattern. And this is a patient with lupus nephritis, and the classical feature of somebody with lupus nephritis is that they stain not only for IgG, but they stain for all the immunoglobulin components that we look for on immunofluorescence. So they stain also positive for IgA, C3, and C1q. C1q is a classical stain that is seen only in patients with lupus nephritis, and if somebody stains positive for C1q, that really tells you that this is a patient that has lupus nephritis. But the classical feature of immunofluorescence for patients with lupus nephritis is what we call full house pattern of staining. They stain for every immunoglobulin that we look for on immunofluorescence. In patients with IgA nephropathy, so it comes from the name, right? So it's IgA staining that these patients have, and where do they stain? They stain mainly in the mesangium. Like if you look at, these are the glomerular capillary loops. They're not staining very well. They're very dark. And you see the IgA staining mainly extending in the mesangial space. And this is what you see in patients with IgA nephropathy. They can also stain for IgG, but IgG is a non-specific stain. As you keep going along the disease course, the glomeruli can pick up these immunoglobulins and that can stain. But if somebody has IgA nephropathy, the dominant stain that you should see then is IgA staining in the mesangium. So that's what helps you make the diagnosis of IgA nephropathy. So what do you use the electron microscopy for? You're basically looking at these immunoglobulin deposits right under the microscope. So this is a patient with lupus nephritis. You see these stains in the glomerular basement membrane of immunoglobulin. This is a patient with post-infectious glomerulonephritis. It's classically described as subepithelial. So this is the glomerular basement membrane. This is the epithelial side, and this is the endothelial side. So just below the epithelium, you have these humps that are formed by these immunoglobulin deposits, and this is classical for patients with post-infectious GN. Whereas this is a patient that has dense deposit disease, where you see just dense staining of the whole glomerular capillary wall with this very strong staining of immunoglobulin. So that is seen in patients with dense deposit disease. So the electron microscopy is mainly used for confirming these immunoglobulins and how they are arranged. But the most important diagnostic criteria or the way to classify this disease is by looking at immunofluorescence. One other feature, this is, when you look at the infiltrates in the glomeruli, the inflammatory infiltrates, most patients have both neutrophils, lymphocytes in them. But in patients with post-strep GN or post-infectious GN, they may have more neutrophils in there as part of their inflammatory milieu. So that is also something that we can look for in the microscope to see what inflammatory cells are they predominantly there. And if they have more neutrophils, it leads you more to think that they have post-strep glomerulonephritis. So we'll talk about each of these diseases individually. So the first one is anti-GBM disease. Again, remember, on light microscopy, you will see glomerular inflammation, crescent formation. They will have AKI with hematuria in a lot of these cases. And when you do a biopsy, that's what you see on light microscopy. And on immunofluorescence, you'll see linear staining of IgG in the basement membrane. So this was a patient that I had seen at Moses a few years back. She was an old woman. She was more than 90 years old that presented with intracranial hemorrhage, and she had an AKI, and a biopsy was done that showed anti-GBM. So we're talking about the light microscope. You can barely see any open capillary loops. You have a lot of inflammatory cells in the glomeruli, and you see this crescent that is pushing this glomerular tuft to the middle. And this crescent has a lot of inflammatory cells. So this is a patient with RPGN. And this inflammatory cells she did not just have in the glomeruli, it was actually also in the interstitium. So it was just severe inflammation that was spilling from the glomeruli into the interstitium, and she ended up having a very severe AKI needing dialysis. So when the biopsy was stained for IgG, you see the linear staining that I was talking about, right? Along this glomerular basement membrane, you see linear and uniform staining of IgG, and that is what makes the diagnosis of anti-GBM. You don't see this in any other condition other than anti-GBM disease. So anti-GBM disease is regarded as a specific and a restricted form of systemic vasculitis. And the interesting thing about it is that it affects only specific organs that contain the autoantigen in the capillary beds. And this autoantigen is the alpha-3 chain of type 4 collagen, and this is found predominantly in the lungs and in the kidneys, and that is why anti-GBM disease is mainly a pulmonary renal kind of manifestation. There is bimodal age distribution. The peak incidence is in the 3rd and 6th decade, and there is a slight overall excess in men compared to women. And most patients present with a combination of RPGN and lung hemorrhage because that's where the alpha-3 chain of collagen is present. In 30 to 40% of the patients, though, they can have an isolated renal involvement and not have any lung involvement at all. It is associated, the common disease association is with ANCA vasculitis. So that was the second case that we presented with the 80-year-old man. His serology was positive for both ANCA and anti-GBM. So you can have ANCA positivity in about 30% of patients presenting with anti-GBM disease, and 5 to 10% of patients presenting with ANCA vasculitis have anti-GBM disease. So the big question would be, if you have somebody with AKI that has staining, that has both serologies positive for ANCA and anti-GBM, how would you make the diagnosis? You would make the diagnosis by a kidney biopsy, and the most important thing on the biopsy would be looking at immunofluorescence, right? In patients with anti-GBM, you would have linear staining of IgG, whereas in patients with ANCA vasculitis, you would have paucity of staining. You will have actually no staining or very little staining of the immunofluorescence microscopy. So that is how you would make the diagnosis between the two of them, because without that, it would be confusing whether the patient has anti-GBM or ANCA vasculitis. Because lung involvement can be present in patients with ANCA vasculitis as well. They can present with alveolar hemorrhage too. So that also will not help you in identifying the two diseases. So in patients with anti-GBM, almost all patients have circulating anti-GBM antibodies detected by ELISA. The light microscopy we talked about generally reveals widespread crescent formation. And the disease for anti-GBM, it's such a severe inflammatory disease that when you do a biopsy, most patients present to the hospital and you do a biopsy, and once either the disease is severe enough that it leads to end-stage renal disease, or the disease is treated and it does not usually undergo periods of relapse once a remission is achieved. So when you do a biopsy, the disease is typically monophasic. All the glomeruli, they show lesions of a similar age as far as pathology goes. Whereas when you talk about patients with lupus nephritis, patients with ANCA vasculitis, they can have periods of remission and then they have a relapse. So they'll have, again, another inflammatory hit, and then they go into remission again, and then they can have another relapse. So when you do a biopsy after many of these relapses, you can see findings of the disease at various time points or at various ages in the biopsy. So the disease is not typically monophasic, but anti-GBM is typically monophasic. All the glomeruli show lesions of a similar age. How would you treat patients with anti-GBM disease? You basically throw the kitchen sink at them because they have just such severely poor outcomes as far as inflammation and end-stage renal disease goes. So the treatment is plasma exchange for about 7 apheresis that they get during a 14-day period. You treat them with cyclophosphamide, prednisone, and if they have lung involvement as well, you need to make sure you give them prophylactic treatments with PCP pneumonia, look at symptoms in the stomach, and give them PPIs as well. But the mainstay is, all the strong medications that you can think of immunosuppression-wise is what you give them. So you give plasmapheresis, cyclophosphamide, and prednisone. And once, if they're lucky enough to achieve a remission, you maintain them with prednisone that is slowly tapered over a period of 6 months to a year. But the disease is treated very aggressively because without treatment, the chances of the patient having end-stage renal disease or even death from severe inflammation is very high. What is the long-term prognosis in patients with anti-GBM? It's not very good, especially if they have severe AKI at the time of biopsy or if they're dialysis dependent. The chances of them surviving, this is looking at patient survival, If they had severe AKI or dialysis over a period of 15 to 20 years, only 50%, 40 to 50% of the patients ended up surviving the episode. Also, when you look at the renal survival, if they have AKI, the chances of them having renal recovery is very low, and most of these patients go on to stay on dialysis. So, so the two clinical factors that matter is how severe the AKI is in patients, and whether or not they're on dialysis because of the AKI. If those two factors are present, then the chances of them having renal recovery is very less. The percentage of crescents on biopsy also matters. So the chances of the patients being on dialysis versus non-dialysis, the higher the number of the crescents and higher the serum creatinine, the more the chances of the patient staying and being dialysis dependent compared to them coming off dialysis. So if they have severe AKI on dialysis, and if you do a biopsy and they have significantly higher percentage of crescents on biopsy, those are bad prognostic signs for patients with anti-GBM disease. So the next we're going to talk about is ANCA vasculitis. So again, the light microscopy is going to show glomerular inflammation, crescent formation in most cases. And when you do immunofluorescence, there won't be any staining or very little staining for the immunoglobulins. And that's how you make the diagnosis of ANCAs. So this is a patient that we had with ANCA vasculitis. We talked about there is severe inflammation in the glomeruli, right? You can barely see any open capillary loops. There are a lot of inflammatory cells in the glomeruli. In this one, there is no crescent formation, but when you look around, you see this glomeruli with this crescent. It's slightly more organized. There may have been a delay in the time the patient got the biopsy, but there is a crescent, and on immunofluorescence, you don't see any staining. So this is a patient that has ANCA disease. So, the ANCA vasculitis, ANCA disease, there has been a lot of change in how the disease is classified. Traditionally, it used to be classified as MP, microscopic polyangiitis, Wegener's, Chugstras, but now, the classification is mainly gone on from these names to just classifying them based on the type of ANCA they have. So if you have somebody with ANCA vasculitis on biopsy, you either classify them as having MPO ANCA vasculitis. It all depends on what serologies they are positive for. So they can either have MPO ANCA positive, PR3 ANCA positive, and about 5 to 10% of patients will not have any positivity for ANCA in the blood work. So they have all the findings on light microscopy and immunofluorescence of ANCA disease, but they're not positive for MPO or PR3 ANCA. So these patients are classified as ANCA negative ANCA disease, and they're still treated the same way as these diseases are. So that is how you would classify patients with ANCA disease. And as far as clinical features go, this is the one where you really have to look into extrarenal involvement. A lot of these patients can have ENT involvement, especially in the traditional one. If they had GPA versus MPA, it was more common in those with granulomatosis polyangiitis with 90%. So they can have nasal crusting, sinusitis, rhinorrhea, bloody nasal discharge, nasal ulcers. Some can also have hearing loss, earache. So you want to ask for all those findings. So ENT involvement is fairly common with ANCA disease. The other one is pulmonary involvement, especially the severe one is alveolar hemorrhage and hemoptysis, but they can also have dyspnea, hoarseness, cough, findings of atypical pneumonia that you would look for if they have lung involvement. Renal, we already talked about, and the disease activity, at least in the studies for ANCA vasculitis, there is a whole Birmingham Vasculitis Activity Score, or the BVAS score. It looks at vasculitis activity in each of the organ systems, and I think the score goes from 0 to 64 or 69, and that's how they classify whether the disease is getting better when they are following patients. It is done mainly in research studies. But that is how disease can be assessed if you're looking for response to therapy as far as disease activity goes, because it's not possible to do a kidney biopsy at every visit to look at how the inflammation is proceeding. So you could look at just looking at these individual organ systems to see how the vasculitis activity is in them. So what is the pathology? So ANCA and anti-GBM most often manifest as crescentic GN, And the inflammatory milieu, it contains a mixture of neutrophils, eosinophils, lymphocytes. So this is not the one that has a predominant neutrophil or predominant lymphocyte. It just has all the inflammatory cells in them. In contrast to anti-GBM, the ANCA glomerulonephritis is characterized by many recurrent bouts of exacerbation. So they have remissions and relapses. So you can have combinations of active necrotizing glomerular lesions as well as chronic sclerotic lesions where they have a lot of fibrosis in the same biopsy specimen. So when we talked about monophasic appearance in anti-GBM, in patients with ANCA vasculitis, especially if you're doing biopsy, a few years or a few months after the diagnosis, you can have both active lesions as well as chronic scarring lesions in the same biopsy specimen. And the hallmark, of course, is that there is an absence or paucity of glomerular staining for IgG. How do you treat patients with ANCA vasculitis? So it is divided into induction phase and maintenance phase. So induction, the first line of treatment these days now is rituximab. This was based upon the RAVE trial that was published in 2010. It was compared, looked at the non-inferiority of rituximab compared to oral cyclophosphamide, and it was found to be non-inferior. So the first line of treatment is either rituximab or daily oral cyclophosphamide for induction. Because of the severe side effects associated with cyclophosphamide, especially if it's a young woman, risk of fertility, malignancy, the risk of worsening infections, because of all those risks, rituximab has a better side effect profile compared to cyclophosphamide. So that has almost become like the first line treatment. But know that both rituximab and cyclophosphamide, as far as effectiveness-wise, are equal for induction of remission. Once you achieve remission, maintenance therapy is with azathioprine. So the IMPROVE trial, which is this one in 2008, compared mycophenolate and azathioprine for maintenance therapy of ANCA vasculitis, and this was the one that showed that azathioprine was superior to mycophenolate. So if you need somebody with ANCA vasculitis to be on maintenance therapy, azathioprine would be your drug of choice. There are certain factors that are associated with higher chances of treatment resistance. So older age and higher creatinine at the time of biopsy. If you have that, the chances of the patients having treatment failure is very high. Whereas once they achieve remission, if they have had lung involvement and if their antibody is PR3 instead of MPO ANCA, they are the ones that have higher risk of relapse after undergoing a remission. So these are the factors that are important whenever we see patients with ANCA vasculitis: how old they are, how bad the AKI is, and do they have lung involvement or PR3 antibody positive. That have important implications, for the future as far as treatment resistance or relapse goes. So then the next one we'll talk about is IgA nephropathy. And so this is a patient. The initial biopsy that I showed was a patient with IgA nephropathy. So the patient had both normal glomeruli on biopsy as well as a glomeruli that had a crescent. So the chances of IgA nephropathy causing crescentic GN is very less, but it can happen because it's more like a less severe form of inflammatory disease. The hallmark we said is you have IgA staining in the mesangium, like you have in this slide. So it is the most common glomerular lesion of all forms of glomerulonephritis. The hallmark is a deposition predominantly of IgA in the mesangium with mesangial proliferation. The clinical features, it can span the spectrum of asymptomatic hematuria to rapidly progressive GN. It's more likely to present with asymptomatic hematuria, minimal proteinuria, mild AKI rather than RPGN. But RPGN cases with IgA can also happen. It occurs in individuals of all ages, but it is most common in the second and third decades of life. So it is mainly a disease of younger men than older patients. So if you have a young man that is coming with hematuria and proteinuria, maybe a mild derangement in kidney function, the most likely diagnosis they have is IgA nephropathy. In Asia, it is the most common form of primary glomerular disease. It accounts for up to 30 to 40% of all biopsies performed there for glomerular disease, whereas in North America, it accounts for about 10% of all the biopsies that are performed. And as I said, it usually manifests as focal or diffuse mesangial-proliferative GNs, right? So there is mainly proliferation in the mesangium, and a very few will show aggressive disease with crescent formation. So it's a little bit unusual for a patient with IgA to present as a crescentric GN. So this is a study looking at 520 patients with IgA nephropathy. Only about 5% of them had RPGN, and the rest, 95%, presented with a non-RPGN type of presentation. Out of those that had a non-RPGN type, the chances of them having reaching end-stage renal disease was very less, only about 3%. Whereas those that had RPGN and reduced kidney function, about 25%, 24% of them ended up needing dialysis. So IgA nephropathy usually does not lead to end-stage renal disease, especially if they don't have RPGN or severe inflammation in the biopsy. So this is the same thing, looking at renal survival. If they have RPGN, it's higher chance of them reaching end-stage renal disease compared to the non-RPGN group. So there is worse renal survival if patients with IgA also have RPGN. So how do you treat it? So the treatment for IgA nephropathy is mainly supportive treatment. It includes control of blood pressure, control of proteinuria with the use of ACEs and ARBs, and dietary sodium and protein restriction, smoking cessation, avoidance of nephrotoxins. So this was the one study that looked at immunosuppressive treatment in patients with IgA nephropathy, and the evidence did not really support immunosuppressive treatment for IgA nephropathy. So, but if you select the patients carefully, and if you have somebody with IgA that has severe inflammation leading to RPGN, I think those are the patients I would be more inclined to treat with immunosuppressive therapy. But if you have IgA nephropathy patients not presenting with RPGN, maybe those are the ones you would just go for supportive treatment and not subject them to the side effects of immunosuppressive treatment, because the evidence for that is very limited. So the next one we'll talk about a little bit is lupus nephritis. I mean, lupus is a diagnosis in itself. It's a whole an R talk in itself. So we will just touch on some important points about lupus nephritis. So we said on immunofluorescence, the classical feature of lupus nephritis is that you have a full house pattern of staining. It stains for all the immunofluorescence or immunoglobulin stainings on immunofluorescence microscopy. And based on the biopsy, we classify lupus by 6 categories, from class 1 to class 6. It's all here. The one that is more associated with severe glomerular inflammation is the class 3 and class 4, whereas class 5 is the one that is associated more with a nephrotic syndrome-like picture, and class 6 is the one where you have more severe sclerosis and damage to the glomeruli already. So that is the classification of lupus nephritis based on what you see on biopsy. So a few features about lupus nephritis. The kidney disease is a big influencer of morbidity and mortality, both through the severity of the disease as well as through the complications of therapy in patients with lupus nephritis. And the circulating immunocomplexes that deposit in the tissues, it causes activation of complement. And that is the activation of complement is what is the most important mediator of certain patterns of glomerular damage. The renal involvement, it can develop shortly after the onset of lupus, but the important thing is that it follows a very protracted course. It is very rare that somebody with lupus nephritis will have an AKI and go on dialysis in the same hospitalization. It is usually a disease where you can get control of it, but patients have frequent exacerbations with remissions and relapses, so they have a very protracted course if they have renal involvement. The renal involvement usually correlates well with the degree of glomerular involvement seen in lupus, so it's mainly a glomerular disease. So the worse the glomerular disease, the worse the renal disease as well. And the presence of low complement, severe hypertension, severe proteinuria, and worse renal disease, you see more of that if they have diffuse glomerular involvement. That's where you see more severity of the disease as well. So these are the things just to remember for patients with lupus nephritis. What if patients with lupus nephritis also have RPGN? They just have a worse prognosis, just like patients with IgA nephropathy. So this is looking at renal survival. Both of them, so all three are looking at renal survival in patients that have with or without RPGN. If they have creatinine more than 2.9 versus 2.9, and if they have crescents more than 60% versus less than 60%. So all these three features, severe AKI, RPGN, and severity of crescents, is associated with more poor renal survival, more higher likelihood of them reaching end-stage renal disease compared to those that don't have these features. How do you treat patients with lupus nephritis? This is where your classification on biopsy becomes important. So patients with class 1 and class 2 disease have very limited inflammation. So in them, you could just give them supportive care, and immunosuppressive meds are not needed unless there is some worsening of the disease. If the creatinine worsens or the proteinuria worsens, that's when you could go to immunosuppressive treatment. Whereas if they have class 3, 4, or 5, those are the ones that really warrant additional immunosuppressive agents. So the treatment of choice in this is actually mycophenolate. It was the ARMS trial that was published in 2009 that looked at the non-inferiority of mycophenolate compared to cyclophosphamide, which was the treatment of choice prior to that. And it showed that mycophenolate is not inferior to cyclophosphamide. And again, because this is a disease that affects young women and the risk of losing fertility with cyclophosphamide and all the side effects associated with it, mycophenolate is the treatment of choice for induction of remission in patients with lupus. This same study also had a maintenance arm, and they compared mycophenolate to azathioprine, and in this one, mycophenolate was actually superior to azathioprine for maintenance therapy. So in contrast to ANCA vasculitis, where azathioprine was superior, in lupus nephritis, mycophenolate is superior to azathioprine for maintenance of remission in patients with lupus nephritis. However, if these women decide to get pregnant or are pregnant, then azathioprine is the treatment of choice because of the toxicity into the fetus associated with mycophenolate. Other treatment modalities, if they fail mycophenolate, cyclophosphamide, then the other treatment modalities, you can add tacrolimus, cyclosporin, and rituximab as well. But the evidence for them is limited compared to what you have for cyclophosphamide and mycophenolate. But these are other treatments that you can use if they are failing therapy with the above two agents. And then the last one that we're going to talk about is post-infectious glomerulonephritis. We're doing could be time. So this is a patient with post-infectious glomerulonephritis, right? So you see, again, severe inflammation in the glomeruli. This one has some capillary loops that are open, but more importantly, it's just the number of inflammatory cells you see in the glomeruli. One of the glomeruli also has a crescent, as you can see here, a cellular crescent. And on immunofluorescence, look, this is the classical one where you have this granular deposition of IgG. This is along the mesangium. This is along the glomerular capillary loops. But the hallmark of this is the granular staining. In contrast to the linear staining that you saw with anti-GBM disease, these diseases, lupus, post-infectious, you see more granular staining of IgG rather than linear staining. So it is an immunologic response of the kidneys that occurs following a non-renal infection. Classically, it was often associated with streptococci, but now it can be seen, we see that with almost any non-renal infection, even with staph or any other infections, you see a post-infectious GN. In some developing countries, post-infectious is the most common cause of acute nephritic syndrome in children, and it accounts for up to 50 to 90% of children presenting with nephritic syndrome in the developing countries. So the typical presentation, usually it's a child that abruptly develops puffiness of the eyelids and edema after the infection, and then they have smoky, scanty urine, hematuria, and increasing blood pressure. Very severe AKI, especially because the amount of inflammation is not severe, and these are mainly affecting children. So the chances of it leading to anuria or renal replacement therapy is very less. So sometimes you can have anuria and nephrotic range proteinuria, but it is a bit rare. The good thing about it is that it is usually a self-limited disease. Usually after 4 to 7 days of hospital admission, the urine volume increases, and that is rapidly followed by resolution of edema and normalization of blood pressure. However, the microscopic hematuria, it can take several months to up to a year to persist. So even if you look at these kids' urines, the hematuria may be persistent for a long time. So the pathology, you have diffuse cellular proliferation, and it contains many neutrophils and monocytes. So neutrophilic infiltrate is the hallmark of post-strep glomerulonephritis. So the immunofluorescence, we said, it's a granular deposition of IgG, and with that complement C3. And the classical findings on electron microscopy are these humps, these subepithelial humps that we showed earlier under the effaced epithelium. So this is the same slide showing the neutrophilic infiltration, and I don't have the humps, but that was shown earlier on the subepithelial side. What is the treatment and outcome? So the treatment of acute post-strep GN is largely supportive because it is a self-limited course. Children almost invariably recover from the initial episode. And the good thing about this, in contrast to all the other diseases we talked about where AKI and renal involvement is associated with poor long-term renal outcomes, in patients with post-infectious GN, the initial episode of AKI, especially if it is in young children, it is not necessarily associated with a bad renal prognosis in the future. And there is little evidence to suggest the need for any form of immunosuppressive therapy because it's usually a self-limited disease, gets better on its own in 5 to 7 days. So to summarize everything, the things to remember from the talk is that the typical clinical features are not always present in patients with RPGN. You need a very high clinical suspicion. The one hallmark is on a light microscopy, crescent formation is what you're really looking for to help you make the diagnosis of RPGN. The immunofluorescence usually helps in establishing the diagnosis, it helps in classifying it, and also it provides an insight into the immunologic pathogenesis of the inflammation. The poor prognostic indicators, they have minor differences depending on the diagnosis, but when you look through, typically the more severe the inflammation, the more severe AKI, more severe the degree of crescent formation, those are all pretty much the poor prognostic indicators, but they have some minor differences with each diagnosis. Options for treatments that have been very well studied in randomized clinical trials are limited. So you really need to weigh the risk of toxicity because of these medications with the potential benefits. So in most cases like this, we usually end up individualizing the therapy. How old is the patient, how much CKD they already have, how bad the scarring and fibrosis is in the kidneys. And if there is very limited chance that this patient is going to recover, then you may want to just give them supportive treatment and not immunosuppressive treatment because of the severe toxicity associated with these diseases. So you have to individualize therapy based on age, the comorbidities, the severity of disease, and the risk of toxicity from the medications. So finally, coming back to the two questions that we had asked, so we'll go back. So I just underlined the important things, right? So this is a 56-year-old woman. She's presenting with hematuria, proteinuria, and she has an AKI with a creatinine of 2.1. 3 weeks before, she had a cholecystectomy, had a wound infection with MRSA, and she was also treated with a cephalosporin. So the C3 level is 64, so a complement level is low. And which one of the following is most likely to be observed on immunofluorescence examination, right? So what is the diagnosis? So this is somebody that has post-infectious GN, right? So you could also think that she could have an AIN as well because she was given a cephalosporin. But the diagnosis of the fact that she has a low C3 level tells you that this is a post-infectious GN. Patients with AIN don't have a low C3 level. And what would you see on immunofluorescence microscopy? So you're going to see the granular capillary wall deposits of IgG and C3, right? So if you look at it, if you have scanty IgG deposits in the mesangium, so this may be seen in somebody with ANCA vasculitis where they have very few deposits in the mesangium, or in patients with IgA that you're doing a biopsy after a while. Linear IgG deposits along the glomerular capillary loop, so you would see that in patients with anti-GBM disease. Mesangial and capillary wall deposits of IgA and C3, you may see that in patients with IgA nephropathy. Granular mesangial deposits of C1q is in patients with lupus nephritis. So this patient with infectious GN, you would see granular capillary wall deposits of IgG and C3. That would be the right answer. Is E. And then the next question is this 80-year-old man. He's presenting with 2 weeks of fatigue and hematuria. He does not have any lung symptoms and he has lower extremity edema. He has a severe AKI with a creatinine of 6.4, and 3 months ago it was 0.9. He's oliguric, so his AKI is severe, and his kidney biopsy shows necrotizing crescentric GN involving 100% of the glomeruli. The important thing in this is that there is linear deposition of IgG along the glomerular basement membrane. So this could, because in his serologies, he has dual positivity for both anti-GBM and ANCA. So this could either be anti-GBM or ANCA disease, but because he has linear deposition of IgG, that tells you that he has anti-GBM disease. So the question is, which is the most important management for this patient? And we said in patients with anti-GBM disease, you treat them with the most aggressive therapy. So the answer would be high-dose corticosteroids, plasmapheresis, and cyclophosphamide. So intravenous rituximab, that was a RAVE trial that looked at patients with ANCA vasculitis. So that would not be the right answer. The right answer would be answer B, because you're treating him as an anti-GBM disease. So that's the right answer. All right, so that's all I have. I'm happy to take any questions from any of you.